A 76-year-old patient with hypertension, hyperlipidemia, hypothyroidism, and RA complicated by ILD is admitted for failure to thrive. You see that the creatinine is 0.8. She has a normal muscle mass. Which of the following will be altered by this patient's situation? Creatinine, cystatin C, or inulin? Give you about 10 seconds to pick. Right. So the answer here, clearly I didn't even highlight it, is cystatin C. So we'll go over why. Let's go over GFR first. So GFR is how much blood flows through the glomerulus over time. And it's very hard to measure as inulin is not easy to measure. So instead, we end up calculating an estimated GFR. This is an eGFR. We often use them interchangeably in the hospital because no one actually gets a true GFR. Sorry for the lack of trigger warning. This is a glomerulus with all of the parts identified, which will potentially come up later on. There are two main calculators we use to calculate eGFR. So in 2021, we finally came up with some new ones that exclude race, which is wonderful and long overdue. The CKD epi-creatinine equation does not use cystatin C, and the CKD epi-creatinine cystatin equation uses creatinine and cystatin C. So you have to figure out what your institution uses. Here we use the top one. We don't use the cystatin C equation. I'm not sure what is used across the street. There's an FYI here. Some medications will actually reduce your GFR, but they have long-term benefit in preserving your GFR. This is why things can get tricky. So if your GFR goes down, your creatinine goes up. And so when you put it into the calculator, your eGFR goes down. ACE inhibitors, ARBs, ARNIs, MRAs, and SGLT2 inhibitors. So lucky for us, all the things that are part of GDMT for heart failure will make your eGFR go down, and then you're not sure if it's an AKI or not. So when you think about things that can reduce the eGFR, you have to look at the equation. And the equation includes three things: age, creatinine, and cystatin C. There are lots of different causes of elevated creatinine, but just to break it down for everyone: acute kidney injury, subacute kidney injury, CKD, meds that lead to a drop in GFR that are nephroprotective, like the ones I had mentioned earlier. There are certain medications that actually just decrease the renal tubular secretion, so the creatinine goes up, but the kidneys are totally fine. There's a list below. And increased muscle mass. So you do have to pay attention. If your patient's a bodybuilder, their creatinine may be 1.2, 1.3, and be totally normal. So I do wonder what Mr. Schwarzenegger's baseline creatinine is sometimes. That one's for Dr. Bajani. Let's move over to cystatin C. So like I said, an elevated cystatin C can reflect a decrease in eGFR. So what can cause that? So AKI, subacute kidney injury, CKD, but obesity can also cause it. So our patient had normal muscle mass, didn't mention obesity. Inflammation can increase her cystatin C. So she had RA and ILD. There's a chance that there is some interplay there. So don't hang your hat on the cystatin C. Alternatively, for whatever reason, corticosteroids also make the same change, even though it's anti-inflammatory. And then hypo or hyperthyroidism. So all to say that this should not become the new procalcitonin. We have to be very careful how we use this. Don't lean too heavily on it. So just to summarize everything on one nice page, remember that you have to look at the equation that feeds into the eGFR. So you first have to understand if your institution uses a cystatin C or not. And then based on that, you have to decide what is causing the change. So it can be an actual change in kidney function through an AKI, CKD, subacute kidney injury, but very often it's related to an alternative process. And that's all I've got.